Good day, everyone. This is Dr. Von, and for this week, we will be discussing about your calcium ion. For this week's learning objective, we will be able to discuss about your calcium body distribution. What is the function of your calcium, and how do we regulate your calcium using those three important hormones? The synthesis and action of those hormones regulating your calcium ion, specifically your parathyroid hormone, your calcitonin, and your vitamin D. Then, the action control for calcium, the clinical significance or the different disorders relating to your calcium level, your hypocalcemia, and your hypercalcemia. And then, the different laboratory methods and interpretations. Your calcium is said to be the fifth most common element in the body. It is actually involved in enzymatic activity or enzyme activity. Remember that your calcium can also act as a cofactor. It is also part of your blood coagulation system, specifically your blood clotting number 4. Clotting number 4, which is your calcium. It is also involved in your excitability of skeletal and your cardiac muscle. Once your calcium is being released by your smooth endoplasmic reticulum, it will then attach to the microfilaments of your skeletal and your cardiac muscle, causing contraction. It is also involved in the maintenance of your blood pressure. So your calcium, 99% of this is actually found in the bone. 1% is found in the circulation and in your extracellular fluid. 15% of your calcium is bound to anions, to your citrate, bicarbonate, and lactate. And 40% is bound to your protein, most specifically in your albumin. Only 45% is free or ionized calcium. The concentration of your ionized calcium in blood is 5,000 to 10,000 times higher than in the cytosol of cardiac or smooth muscle cells. Maintenance of this large gradient is vital to maintain the essential rapid influx of your calcium. According to Rodriguez, among the three forms of this ionized calcium, your ionized calcium is the sensitive and the most specific marker for calcium disorders. So this diagram will show us the distribution of your calcium. Again, this is the fifth most common electrolyte in comparison to your sodium, potassium, chloride, bicarbonate, and other substances. So you see your calcium, your blood plasma is approximately, the calcium is around 5 milliequivalents per liter. Your interstitial fluid is around 3 milliequivalents per liter, while your intracellular fluid is only around 0.2 milliequivalents per liter of your calcium. So your ionized calcium should be maintained at near normal levels during surgery and in critically ill patients. Why do you think? We have to check first the serum calcium of our patient prior to surgery because a decrease of your ionized calcium can impair myocardial function. There could be cardiac arrhythmia if the patient has a low level of your serum calcium. A decreased amount results in impaired myocardial function and neuromuscular irritability. There could be irregular muscular spasms or your tetany. That's why prior to surgery, guys, it is prudent really that we have to check for your serum calcium. So in terms of regulating your calcium ion, there are three important hormones which regulate it. Number one, your parathyroid hormone, which is secreted by your parathyroid gland. Your activated form of your vitamin D, specifically your 125 dihydroxycholecalciferol, and lastly, your calcitonin. So your parathyroid hormone is produced by your parathyroid gland. Your vitamin D, we will see where just the vitamin D is being synthesized. And lastly, your calcitonin is being secreted by your thyroid gland. Very good. So first, let's just have a short review of your parathyroid hormone. Again, your parathyroid hormone stimulated by decreased ionized calcium. So once there is a decreased level of your serum calcium, your PTH will be released. So it has two important actions, sa bone and sa kidneys. Sa bone, anong ginagawa niya? There will be bone resorption, in which activated osteoclasts break down and subsequently release your calcium into your ECF para tumaas yung calcium level. In your kidneys, it can cause conservation of your calcium, or it conserves your calcium. There also be renal production of your active vitamin D. So, sa kidneys, minapataas niya, increasing tubular reabsorption of your calcium ions. Now, let's proceed with your vitamin D. So, your vitamin D, which increases your calcium absorption in the intestine. So, ang action naman ni vitamin D is towards your intestine. Increases calcium absorption. It also enhances the effect of your parathyroid hormone on your bone resorption. So, si parathyroid hormone and vitamin D, ang main effect talaga nila is to increase your serum calcium. So, the activated vitamin D3 is obtained from the diet or exposure of skin to sunlight. Your vitamin D3 is then converted in the liver and still in active form of your vitamin D. However, in the kidneys, your inactivated vitamin D3 is converted into its activated form, which is your 1,25-dihydroxycholecalciferol. So let's check this diagram. Again, your 7-dehydrocholesterol in your skin, by the action of the UV rays B of your sun, converts this 7-dehydrocholesterol into its pre-vitamin D3, which is your cholecalciferol. Again, ang 7-dehydrocholesterol na matatagpuan sa ating skin by the action of your UV rays B will be converted into pre-vitamin D3, which is your cholecalciferol. Your cholecalciferol will undergo hydroxylation by the action of your 25-hydroxylase, making now your cholecalciferol into 25-hydroxy-vitamin D3 or your calcidiol. But this calcidiol is still inactive. It needs to go to the liver to become biologically active. In the kidney, by the action of your 1-alpha-hydroxylase, the 25-hydroxy-vitamin D3 is now converted into its biologically active form, which is 1,25-dihydroxy-vitamin D3. So yung 1 dito nanggaling sa liver na hydroxylation, yung 25 dito nanggaling sa hydroxylation sa kidney. That's why it's di kasi twice na nangyari ang hydroxylation process. It is now called your 1,25-dihydroxy-vitamin D3 or your calcitriol. So anong effect ng ating calcitriol sa ating katawan? First, small bowel or small intestine calcium absorption, which is the main net effect of your vitamin D3. There could also be renal calcium reabsorption, bone calcium release. It also affects approximately 2,000 genes, regulation of your cell proliferation, and affects every tissue, including your brain. It also affects your leptin signaling. So your leptin signaling has something to do in decreasing your appetite because the function of your leptin is actually produced by your fats, and this leptin will cause now the suppression of your appetite. But our main concern here is always all about your calcium absorption. Yun yung dapat nating malaman. So again, your vitamin D, it's a lipid-soluble hormone that binds to a typical nuclear receptor, analogous to your steroid hormones. Remember, your vitamin D is a sterol, comes from your cholecalciferol. It's a sterol, similar with your sex hormones, similar with your thyroid hormones. Since it is a lipid hormone, it will go directly into your nuclear receptor. Because it is lipid soluble, it travels in the blood bound to your hydroxylated alpha globulin. There could also be extrarenal sites of the active form of your vitamin D. So, si active form ng vitamin D hindi lang matatagpuan sa ating kidney, but it could also be found in your placenta and your granulomatous tissues. Why do you think na merong tayong active form sa extrarenal site na placenta? Because of the growing fetus. The growing fetus needs a lot of calcium for growth and development that will be supported by your vitamin D. What are the effects of your active form of your vitamin D3? Of course, it promotes intestinal absorption of your calcium. It causes synthesis of calcium-binding protein and related facilitated transport. It has also slight effects to increase calcium reabsorption in kidneys. So, meron din siyang effect patungo sa ating kidneys to increase your calcium reabsorption. Again, it works with your PTH to cause calcium resorption from the bone, which activates your osteoblasts to activate osteoclastic to resorb your calcium. We have different laboratory methods to identify our vitamin D3. However, your 25-hydroxy vitamin D or your inactive form of your vitamin D is a better marker since it has longer half-life. So around 2 to 3 weeks versus your active form, which is only 5 to 8 hours. So the reference method that we do is your dual mass spectrometry. Still, you're following the principle of your absorbance. The values are influenced by sunlight exposure and latitude. So there are around 35 metabolites of your vitamin D2 and as well as your D3. However, there are only 2 clinically important. So this is now the review of how your parathyroid hormone and your vitamin D increases your serum calcium. So sa intestine natin, yung parathyroid hormone, wala siyang action. Ang vitamin D, increase calcium and phosphate absorption. Again, vitamin D, increase calcium and increase phosphate. Tatandaan natin yun. So, si vitamin D, papataasin ang calcium and phosphate. How about sa kidney? Your parathyroid hormone causes increased calcium reabsorption, decreased phosphate reabsorption, and increase active vitamin D by increasing your alpha hydroxylase. Sa vitamin D naman, sa action ng kidney is to increase your calcium and phosphate also. So sa vitamin D, walang pili. Calcium and phosphate ang kanyang pinapa-increase and also increase urinary calcium. Your bone can cause, ang parathyroid hormone sa bone cause calcium and phosphate resorption. How about sa vitamin D? At normal levels, calcium and phosphate deposition. However, at high toxic levels can cause calcium and phosphate resorption. So now, what is the net effects of our parathyroid hormone and vitamin D sa ating blood? Some parathyroid hormone will generally increase your serum calcium and decrease your serum phosphate. Si vitamin D naman, again, increase serum calcium, parehas sila ni parathyroid hormone. However, it also increases your serum phosphate. Again, parathyroid, increase ang calcium, mababa ang phosphate. Si vitamin D, parehong tataas ang serum calcium and your serum phosphate. Si calcitonin naman. Your calcitonin, it originates in your parafollicular C cells. So remember, your calcitonin is being produced by your thyroid gland. It is secreted with a concentration of calcium increases hypercalcemia. So in short, pag mayroong calcium, tataas yung calcium level, your calcitonin will be stimulated because it inhibits the action of your parathyroid hormone and vitamin D kasi nga ayaw natin ng too much na calcium. So si calcitonin ang nagpapababa ng ating calcium level. Your calcitonin acts to decrease your plasma calcium levels, while your parathyroid and your vitamin D acts to increase your plasma calcium. Only calcitonin causes a decrease in your plasma calcium. So you already know about that. Calcitonin is synthesized and secreted by your, parafollicular cells of your thyroid gland. The major stimulus of calcitonin secretion is a rise in your plasma calcium levels. Chronic excess of calcitonin does not produce hypocalcemia. Kasi nga, di ba, calcitonin, ang effect ng calcitonin is pababain yung calcium. Pero a chronic excess of your calcitonin does not necessarily produce your hypocalcemia. And removal of parafollicular cells does not cause hypercalcemia. Again, it is still your parathyroid hormone and your vitamin D3 regulation dominate. Ang effect ng parathyroid hormone and your vitamin D3 is greater compared to the effect of your calcitonin. So for your laboratory methods for calcitonin detection, we have this pentagastrin stimulation test. Ano tong pentagastrin stimulation test, Doc? So we give pentagastrin via IV administration, approximately 0.5 microgram per kilogram body weight over 5 seconds. Then we collect the blood sample. Then we check for the baseline level. The levels after first, second, fifth, and 10 minutes of administration of your pentagastrin. The purpose of this pentagastrin, it is a diagnostic sensitivity for your medullary thyroid carcinoma is increased by pentagastrin stimulation before your calcitonin level testing. So this is now the interpretation of your pentagastrin test. Pag less than 10, normal, or 80% of the adults. If around 30 to less than 50, still around 5% of the normal adults could still be normal. But if it's greater than 50 to less than 100, or if it's greater than 100, there is already a possibility of your medullary thyroid carcinoma or other thyroid pathology. So in short, your pentagastrin has greater sensitivity in your medullary thyroid carcinoma. This is a form of thyroid carcinoma that is very aggressive. So this is now a review of the actions of your different hormones. So just a review lang natin. Your parathyroid gland, again, pag mayroong hypercalcemia, kakailangan pa ba natin na maraming calcium? Of course, hindi na. So it will inhibit your parathyroid gland to secrete your parathyroid hormone. However, in cases when there is a low level of your calcium level, it will stimulate your parathyroid gland to secrete your parathyroid hormone. Kasi nga, ang effect or net effect ni parathyroid hormone is to increase your calcium level. In bone, it causes osteoclastic activity, releasing now your calcium and your phosphate group. It also, in the kidney, parathyroid hormone promotes absorption of your calcium, excretion of your phosphate, and activation of your renal alpha hydroxylase. This renal alpha hydroxylase can cause the activation of your inactive form of your vitamin D, which is your calcidiol. This calcidiol will be converted or can be activated in the kidneys. Then it will be converted into its active form, which is your calcitriol, which is 1,25-dihydroxy vitamin D. In the intestine, this activated vitamin D promotes intestinal absorption of your calcium and your phosphate, while in the kidneys, your vitamin D promotes renal reabsorption of your calcium and your phosphate. So this is now the summary of the regulation of those three important hormones. So meron din tayong, once your blood is acidotic or alkalotic, what will happen to our calcium level? Pag acidotic, it promotes the leaching of your calcium from the bone. So your hydrogen displaces your calcium from the protein. Pag alkalotic, ano namang nangyayari? It causes plasma protein to have greater negative charge, meaning mas nagbabind yung ating calcium sa ating protein. Pag acidosis, mas lalong natatanggal ang ating calcium sa ating protein. Pag alkalotic, mas lalong nagbabind ang ating calcium sa ating protein. So, once there is acidotic or alkalotic, then there will be changes of your serum calcium. Again, ano nga nangyayari? Pag nagiging acidotic, mas lalong na di-displace ang ating serum calcium sa ating protein. Therefore, mas tataas ang ionized or free calcium. Pag alkalotic, anong nangyayari? Mas lalong nagiging negative charge ang protein, mas lalong nagbabind ang ating calcium sa ating protein. Therefore, bumababa ang ionized calcium or your free calcium. Let's talk about the different clinical significance of your calcium disorder. So for your calcium disorder, it is subdivided whether it is hypocalcemia and hypercalcemia. So these are the general signs and symptoms if patient is manifesting with hypocalcemia. We have your neuromuscular irritability. There could be paresthesia or numbness, pricking sensation, muscle cramps, tetany, and your seizure. So we have a test or physical exam that we do to our patient to detect whether the patient has your tetany or a low level of your hypocalcemia. Meron kaming tinatawag na Vostek sign. Ano yung Vostek sign, Doc? So this Vostek sign, we tap the masseter, the facial masseter muscle of the patient, and then when we tap it, then there will be cramps or contraction that will happen. So there is now a neuromuscular irritability. Pag sinabing Vostek sign positive, then that is a very good indicator that the patient has hypocalcemia. Meron kami isa pang ginagawa, your Trousseau sign. Sa Trousseau sign naman, nilalagyan namin ng BP cuff ang patient, parang binibipihan ng patient, tapos we will wait for a certain time, and if there is flexion of your wrist and extension of your fingers or contractions of your fingers, then that is already a neuromuscular irritability, which is a good indicator of hypocalcemia. There is also cardiac irregularities. That's why, kaya nga, prior to surgery, dapat there is normal level of your calcium because it can cause certain arrhythmia or heart block. And ayaw nating mangyari sa patient while ginagawa natin ang surgery. For hypercalcemia, there could also be a neurologic symptom similar with hypocalcemia. So this is very non-specific, and other GI manifestations which are also non-specific. For the renal, we have nephrolithiasis and nephrocalcinosis. Anong difference ng dalawa, Doc? Pag sinabing nephrolithiasis, these are actually your kidney stone. Pag your nephrocalcinosis or your Albright's calcinosis or your Anderson-Carr kidneys, it is actually a deposition of your calcium sa parenchyma sa kidneys due to your hyperparathyroidism. So in short, there is deposition of your calcium sa parenchyma mismo ng ating kidney. So mild hypercalcemia usually are asymptomatic. However, if you have moderate or severe hypercalcemia, then that's the time that the patient becomes symptomatic. So what's the difference between primary hypocalcemia and your secondary hypocalcemia? So ang difference ng dalawa, go back again sa ating mga na-review dati. Pag primary, saan nga? The primary organ that secretes your parathyroid hormone. So that's gonna refer to your parathyroid gland. So any problem that can cause destruction of your parathyroid gland, then there could be primary hypocalcemia. So what will be the serum level of your parathyroid hormone? Of course, the serum level of your parathyroid hormone will be low kasi nga primary hypocalcemia. Ang nagsisikret ng parathyroid hormone is your parathyroid gland. Kung may sira sa parathyroid gland, hindi na siya makakasikret ng ating parathyroid hormone. Mababa or low parathyroid hormone, therefore that's a primary hypocalcemia. Ano naman ang secondary hypocalcemia? So sa secondary hypocalcemia, okay naman ang ating parathyroid gland, nakakasikret ng parathyroid hormone. However, the target organ of your parathyroid hormone does not respond to your PTH. It could be that it is resistant to your parathyroid hormone. Meron kang level ng parathyroid hormone, however, your kidney is being destroyed. Hindi siya makaka-absorb ng calcium. So what is the expected level of your parathyroid hormone? In secondary hypocalcemia, there is high level of your parathyroid hormone because your renal is resistant to your PTH. Sira kasi ang ating kidney kaya hindi siya nagre-reabsorb ng calcium. So as a mechanism, dapat taasan niya ang PTH. So that's your secondary hypocalcemia. Meron tayong tinatawag na muscle fatigue. So what is your muscle fatigue? Again, what is a normal muscle contraction? Once your calcium is being released into the cell, it will cause the filament in your muscle fiber, whether cardiac or skeletal muscle, to contract. Pag cause ng relaxation, anong nangyayari dapat? Yung calcium dapat siyang nire-reuptake or nisa-store again, allowing the muscle filament to relax. However, if you have muscle fatigue, anong nangyayari? There is calcium leaking into your muscle cells. So, a calcium leaking or a tired muscle channel leaks calcium ions, weakening now your contraction. So, that's actually the pathophysiology of your muscle fatigue because of the leaking channels. Just remember that. So we have different clinical significance or disorders that will result into hypocalcemia or hypercalcemia. However, these different diseases are not pathognomonic, meaning pag sinabing hypocalcemia, hindi siya agad-agad na would mean a certain disease because there are a lot of diseases that we can relate whether it is hypocalcemia or your hypercalcemia. So hypocalcemia, again, your primary hypoparathyroidism, meaning may sira ang ating parathyroid gland. Pwedeng destroyed ang ating parathyroid gland or during surgery, meron tayong thyroidectomy or total thyroidectomy. And remember, your parathyroid gland is just located posterior to your parathyroid gland. So in short, the most common complication of your parathyroid or of your thyroidectomy is your destruction of your parathyroid gland. Pag nasira ang ating parathyroid gland, mababa ang ating parathyroid hormone, mababa ang calcium sa ating katawan. So that's why it's a primary hypothyroidism causing hypocalcemia. There could also be hypomagnesemia or hypermagnesemia, hypoalbuminemia, and other diseases. But I want you to take note about this hypomagnesemia and your hypermagnesemia. So kahit mababa or sobrang dami ng ating magnesium, it can still lead to hypocalcemia. How is that, Doc? How is that even possible, Doc? Once you have chronic hypomagnesemia, has also become recognized as a frequent cause of your hypocalcemia. Your hypomagnesemia may cause hypocalcemia by 3 important mechanisms. Tatandaan, it inhibits the glandular secretion of your PTH across the parathyroid gland membrane. In short, i-inhibit niya ang pagsisikret ng PTH, kaya mababa ang calcium level. Pangalawa, it impairs parathyroid hormone action at the receptor site on the bone. In short, sisirain niya or i-impair niya yung receptor site sa ating bone. Kaya kahit meron kang PTH, hindi pa rin gumagana ang PTH natin. Pangatlo, it causes your vitamin D resistance. You have vitamin D, but your vitamin D can not act to its specific receptor. So that's why we have hypocalcemia in the presence of hypomagnesemia. Again, ano yung tatlong yon? Number 1, inhibit niya yung secretion ng PTH. Pangalawa, ini-impair niya yung receptor site sa bone ng ating PTH. Pangatlo, ginagawa niyang vitamin D, it causes vitamin D resistance. How about hypermagnesemia, Doc? An elevated level of your magnesium may inhibit PTH release and target tissue response, perhaps leading to hypocalcemia and hypercalciuria. So your elevated level also, ini-inhibit niya rin yung level ng ating parathyroid hormone release causing hypocalcemia. How about pseudo-hypoparathyroidism? In your pseudo-hypoparathyroidism, it is a rare hereditary disorders in which your parathyroid hormone target tissue response is decreased or there is end organ resistance. Again, you have a normal level of your PTH, kaya lang nagiging resistant sa PTH. Hindi gumagana yung ating mga specific organs specific for your PTH. Pseudo-hypothyroidism. PTH target tissue response is decreased because of end organ resistance. We have also other, how about for your hypercalcemia, Doc? So meron tayong primary hyperparathyroidism. So it could be caused by certain tumors in your parathyroid gland causing an excessive levels of your PTH. So pag maraming PTH, anong nangyayari? There could be hypercalcemia. Next, what else? We have also your hyperthyroidism, different malignancies such as your mga multiple myeloma, increased vitamin D, your thiazide diuretics, and your prolonged immobilization. The second leading cause of your hypercalcemia is associated with various types of malignancy, with hypercalcemia sometimes being the sole biochemical marker for the disease. So many tumor produce your ano nga yung hormone na pinoproduce ng ating malignant tumors kung bakit nagkakaroon tayo ng hypercalcemia? It is your, ano nga yun? We discussed this in your parathyroid gland. It is your PTH-RP, your parathyroid hormone-related peptide. So this is your PTH-RP, which binds to normal PTH receptors and causes increased calcium level. So your PTH-RP also resemble just like your parathyroid hormone, which also acts directly to your PTH receptor, causing increased calcium level. Kaya nagkakaroon ng hypercalcemia. So in patients with hypocalcemia, what are the common manifestations of patients with hypocalcemia? Of course, patients often have common physical features including short stature because of low levels of your calcium, obesity, shorted metacarpals and metatarsals, and abnormal calcifications. Hi everyone, good day, this is Dr. Von, and for this week, we will be discussing about your phosphate, other electrolytes, and your anion gap. For this week, our learning objective is to know the different functions of each of these electrolytes, your phosphate lactate, and know the clinical importance or significance to understand why we need to measure each. Then, to know the different specimen considerations, identify the different methods to be used for its determination, and lastly, we have to determine the normal range of these electrolytes. So first, we will be discussing about your phosphate. I know that you are already familiar with the phosphate, the control. Remember your calcium homeostasis. Remember that it also, your hormones that controls your calcium is also the same hormone that will regulate your phosphate. So we will see later on. So it said that your phosphate is found everywhere in your living cells. Remember that the genetic materials, your deoxyribonucleic acid and your ribonucleic acids are complex phosphodiesters, meaning they are also composed of your phosphate group. So your phosphate participate in many of the most important biochemical processes because remember, in your glycolysis, in your citric acid, phosphate is involved in the transfer of your energy. And lastly, it is also inversely related to calcium. So as what I said, remember your calcium homeostasis, the same hormones that are going to regulate your phosphate. So we'll see that later. Here, your phosphate is said to be the reservoirs of your biochemical energy, so including your ATP, creatine phosphate, and your phosphoenol pyruvate. So all of these substances is composed of your phosphate. And also your red blood cells. Your red blood cells has this 2,3-DPG or your 2,3-BPG, which is your biphosphoglycerate. So again, in hematology, what is the action of your 2,3-BPG in your red blood cells? The alterations in the concentration of your 2,3-BPG in your red blood cells affects the affinity of your hemoglobin for oxygen. So in short, pagtaasan natin ang levels ng ating 2,3-BPG, anong mangyayari? With an increase facilitating the release of your oxygen in tissue and a decrease making oxygen bound for hemoglobin. Pag mataas, nare-release ang oxygen. Pag mababa ang levels ng 2,3-BPG, nagiging ang oxygen nagbabind sa ating hemoglobin. So that's the function of your 2,3-BPG. So remember that your phosphate is involved in the different biochemical processes. It participates in many of the most important biochemical processes, and it's also a reservoir of your biochemical energy. So remember, glycolysis is one of the processes, biochemical processes, that is used by our body to generate energy. And remember, phosphate is a reservoir of your biochemical energy. That is why phosphate is involved in your glycolysis. So biochemistry, I know seeing this diagram, you really don't like this kind of diagram. I guess same to you guys. I can still remember during my board exam sa biochemistry. So biochemistry is the first subject during our PLE. And since biochemistry, anything about chemistry, I really don't like chemistry. Swear, so napaka-ironic na I am teaching clinical chemistry. So I don't like biochemistry. And since hindi ko siya, kasi nahihirapan ako kasi you have to memorize everything. It's not a matter of just familiarization. In order for you to familiarize everything, diba, you have to memorize. Kasi nga, hindi mo naman ito mapafamiliarize, mapafamiliarize if you're not going to memorize all of these steps. So, sobrang daming step na kailangan i-memorize, the action of the enzyme and all, anong mga energy na kailangan and so the like, and pati mga disorder. For example, kulang ka na dito ng enzyme, may mga certain disorder na. So, biochemistry is my least favorite subject ever since medtech time. Kasi nga, napakahirap. Ang daming i-memorize and I don't like memorization. Mas gusto ko yung mga kailangan lang tandaan, i-familiarize, and as long as you know the processes, it's easier for you to grasp the idea. I don't like really memorization. So during my PLE exam for biochemistry, since first subject ang biochemistry, so in short, dapat kong pagandaan. Kasi nga, if mababa na ang grades ko, if bad mood na ako sa biochemistry, so for the rest of the exam, in short, mababa na rin ako, mababad mood na ako, so wala na akong gana mag-answer ng exam. So, biochemistry, pinag-aralan ko siya, double time, since ayoko siya, since nahihirapan ako sa biochem, so double time, kailangan ko mag-double time, mag-aral, aralin lahat, yung during the review talagang focus ako, pero, during the board exam, since first subject siya guys, so, pray lang dito kay Lord, Lord, please, kahit sa number 1 lang. Kasi the number 1 will determine what will be your fate all along the test. So, kahit sa first question pa lang, Lord, sapat sa first question. Dapat matama na ako ang first question para at least sa mga next following question, at least na ako'y confidence na mo answer. Kaya tama ako sa number 1, sure ko sa number 1. So, when I read the first question, blah, 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 blah. Oh my God. Parang hindi ata ito na-discuss sa review. Parang hindi ko dinabasa to. Parang wala dito sa med school. Sige lang, Lord. Skip ko lang muna, baka sa number 2 makakasagot na ako. So, I tried to read another. So, skip ko muna ang number 1. So, nag-number 2 ko muna. Number 2, blah, 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 blah. Shit, related lang siya sa number 1. So, correlated ang question. Para siyang case analysis na connected sa number 1. Still, I still do not know this. Sige lang, baka sa number 3, matama ako. So, skip ko sa next, blah, blah, blah. So, nagbasa ko number 3, blah, 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 blah. And still, in number 3, I still do not understand and do not know the question. It was really difficult. So, anong ginawa ko? From number 3, bumalik ko number 1, sinagutan ko na lahat, hindi na ako nag-skip, and I just tried my best to answer. Parang confidence na lang kita. Parang ito. Parang wala pa akong letter B, tapos maganda ang letter B. B na naman ako. Ay, it's really difficult, and parang confidence na lang yung nagdala ato, and ang way of thinking ko, pag mahirap ang question, ginaisip ko na lang na pag hindi ko to alam, most probably hindi din to alam na makatabi ko. Majority of them, parang siguro for sure, hindi din to nila alam kasi hindi tinuro to sa review center. Almost all of us have the same review center, so pantay-pantay lang ang labanan kasi at the end of the day, no matter how, kung lahat kayo nahirapan, it's still based on the MPL. So at least pantay-pantay lahat. So it's better na mahirap ang exam kasi nga pantay-pantay na nahihirapan ang lahat. So at the end of the exam, when I asked my friends, it was really hard, guys. As in like wala gitudo sa med school, wala gitudo sa review center. It's really different. Kaya nga sa board exam nyo, you will really encounter questions na you never heard, you never learned at all. So may experience yun din yan soon. Kaya biochemistry is really one of my lowest subjects sa PLE exam. And also, pati man sa aking medtech time, clinical chemistry was also my lowest subject. Very ironic nga, clinical chem ang aking tinuturo. Very ironic. Kung ano pa mga subject na nahihirapan ako, ito pa yung ginaturo ko. Parang napaka-ironic. So anyway, again, we'll just review I don't want you to memorize this. All I want you to know is why is it your phosphate is involved in your glycolysis and other biochemical processes? Remember, your glycolysis has 2 important phases, right? We have your energy investment phase. Diba sa first step, meron tayong tinatawag na energy investment phase. Ang sa next part is we have energy generation phase. So, anong ibig sabihin yan, Doc? Diba sa first 3 steps ng ating glycolysis, yan yung investment phase. Ibig sabihin yan is uutang tayo ng energy. Uutang tayo ng phosphate sa ating ATP para mag-undergo ang processes. Kasi nga, if walang energy, then the process will not occur. Pero sa second phases dito, magkakaroon tayo ng energy generation phase. Dito na tayo nagkakaroon ng energy. Kaya nababayaran natin yung utang na ginamit natin during sa ating investment phase. Check natin Remember, your ATP has your phosphate, right? Glucose to glucose 6-phosphate. Ano ang first enzyme na gumagamit nito para to convert your glucose to glucose 6-phosphate? It's your, from the name itself, para transfer of phosphate group. It's your hexokinase. Automatically dapat yan. When you hear the word kinase, it's a transfer of phosphate group. Kaya gumagamit ka ng ATP, then your ATP, since you used your phosphate, your ATP becomes ADP. From glucose, you add phosphate here from the ATP, nagiging glucose 6-phosphate. Next, anong nangyayari? Nagkakaroon ng isomerization, kaya nagiging fructose 6-phosphate isomerization. Basically, it's just the same. It's a matter of the rearrangement of your molecule. Parang mirror substance lang ito. Glucose 6-phosphate, fructose 6-phosphate. Then, what happens next? Your fructose 6-phosphate again will be converted into fructose 1,6-biphosphate. Anong enzyme ang ginagamit natin dito? It's still your kinase, but it is your phosphofructokinase. So, phosphofructokinase, it still uses your phosphate. And again, there is a word kinase, meaning it is the use of your phosphate to transfer your phosphate. So, ATP, nagiging ADP. So, in short, your fructose 6-phosphate, nag-add ka na another phosphate group, kaya nagiging fructose 1,6-biphosphate. So in short, the first step is just a energy investment. Ilang ATP ating nagamit dito? 2. Pang-convert ng glucose to glucose 6-phosphate to become from your enzyme hexokinase, isang ATP. For fructose 6-phosphate to convert into fructose 1,6-biphosphate, kailangan tayo ng another energy. So your ATP. So in short, a total of 2 ATP. Pero your glucose here will be converted into 3 molecule, your 3-glyceraldehyde. Remember that your glucose is 6 molecule. Iko-convert siya into 3 molecules. In short, dalawang substance ang na-form. Kaya dito, 3-glyceraldehyde P. Sa process na ito na yung proseso na kung saan nagkakaroon na tayo ng ATP generation. Dito, nakikita nyo, there will be ATP formation and another ATP formation. 2 dito kasi nga dalawang substance. 2 din dito kasi nga dalawang substance. Kaya a total of 2 pyruvate. So dito sa energy generation, nagkakaroon tayo ng 4 ATP. But remember, in your investment, may utang tayo ng 2 ATP. So in glycolysis, we have a total of 2 ATP. So guys, this process is I just want to show you that in glycolysis is that we need your ATP for us to generate more ATP. So in short, your phosphate is essential in the step. So that's why your phosphate is essential in different biochemical processes. So ayun, yan yung gusto kong ipakita sa inyo, that your phosphate is involved in the different biochemical processes. Again, don't have to memorize this, hindi naman to biochemistry. Alam ko ayaw nyo naman din to i-memorize. Of course, hindi na to kailangan na. It's okay. Next, your phosphate. So how do we regulate your phosphate? So regulation, phosphate may be absorbed in the intestine from different dietary sources. So still including your calcium. Remember your calcium, di ba, na pwede din siyang i-reabsorb sa ating intestine. So kasama ng ating phosphate. So released from cells into the blood and lost from bone. So in healthy individuals, all of these processes are relatively constant and easily regulated by renal excretion or reabsorption of your phosphate. So your phosphate could be just easily be reabsorbed from the kidneys or can be excreted also from your kidneys. That's also one way of regulating your phosphate. So these are the different hormones or conditions affecting your phosphate level. Again, remember your vitamin D, your calcitonin, your parathyroid hormone, that is one involved in your calcium homeostasis. We already discussed what will happen to your phosphate level. But Doc, how about your growth hormone? Check natin. Again, for the regulation of your phosphates, your vitamin D acts to increase the phosphate into the blood. So increases both phosphate absorption in the intestine and phosphate reabsorption in your kidney. How about po yung growth hormone, Doc? So your growth hormone, increased secretion or administration of this hormone, specifically your growth hormone, phosphate concentrations in the blood may increase because of decreased renal excretion of your phosphate. So your phosphate has 3 important forms. We have your free, complex with ions, and protein bound, but majority are actually in free form. So in terms of the distribution of your phosphate, so your total phosphorus is approximately about 12 milligrams per deciliter or 3 to 4 milligram deciliter in organic phosphate. So predominantly intracellular anion ang ating phosphate. So 80% of your phosphate is actually found in your bone, 20% in your soft tissues, and less than 1% only which is active in your serum or your plasma. So tingnan natin dito. This is your phosphate and your organic anions. Kita natin dito sa diagram that your phosphate is a predominant intracellular ion. Kina mo, intracellular ion. And a small portion lamang is only an extracellular, approximately 1%. So in terms of a clinical application of your phosphate, mayroon tayong tinatawag na hypophosphatemia when there is already a decreased serum level of your phosphate. So hypophosphatemia can be caused by increased renal excretion as well as with your hyperparathyroidism. Kasi nga, remember, increased renal excretion. Remember, your kidneys can excrete your phosphate, diba? It's one of the regulation mechanism of your phosphate. So in short, pagtaasan natin ang renal excretion, bababa ang phosphate level sa ating dugo. Kaya nagkakaroon ng hypophosphatemia. Decreased intestinal absorption as well as vitamin D deficiency or antacid use. Because of decreased absorption, walang intestinal absorption ng phosphate, in short, mababa din ang level ng phosphate sa ating dugo. Also, your antacid can inhibit the absorption of your phosphate patungo sa circulation because of your antacid. So these are the different disorders that will lead into hypophosphatemia. Hypophosphatemia occurs in about 1 to 5% of hospitalized patients. So these are just merely different disorders, but I want you to remember bakit sa alcoholism nagkakaroon tayo ng hypophosphatemia. Hypophosphatemia or alcohol abuse is the most common cause of severe hypophosphatemia. So Doc, bakit po tayo nagkakaroon ng severe hypophosphatemia because of your alcoholism? It's because probably as a result of poor food intake. Remember that your phosphate comes from your diet. Again, could also be due to vomiting. So when we vomit, then of course we excrete a lot of your phosphate. Kaya bumababa ang level ng ating phosphate. And nagkakaroon din tayo ng marked phosphaturia, meaning increased excretion of your phosphate. So these are the reason why nagkakaroon tayo ng hypophosphatemia sa ating alcoholism. So another conditions, hyperphosphatemia with acute or chronic renal failure. So in short, pag mayroon tayong renal or chronic renal failure sa ating kidney, anong nangyayari? Nagkakaroon ng hyperphosphatemia. Remember that your kidneys is involved in the excretion of too much phosphate. Pag nasira ang ating kidney, anong nangyayari? Hindi natin napapalabas ang ating phosphate. Kaya nagkakaroon tayo ng hyperphosphatemia. Also, increased intake, increased diet, so absorption in our intestine. We have also increased release of your cellular phosphate because remember that your phosphate is intracellularly, majority of your phosphate is intracellularly located. So, increased breakdown of cells will cause severe infection. Caused by severe infection, intensive exercise, neoplasm, and intravascular hemolysis. So, you may also have high levels of your phosphate from prolonged exercise. Bakit kaya nagkakaroon tayo ng hyperphosphatemia during intensive exercise or prolonged exercise? Because it can lead to muscle damage. So remember that certain athletes and distant runners may have this kind of condition, your rhabdomyolysis. So lysis of your muscle cells. Remember, and these muscle cells may contain increased level of your phosphate. Thus, this can lead to hyperphosphatemia. Sorry for that. Or anion gap. So, Doc, ano po ba yung anion gap? So, yung anion gap is a very useful tool for us useful in indicating an increase in one or more of your unmeasured anions in the serum. It's also essential for quality control of your analyzer used to measure your electrolytes. So your anion gap is basically the concentration difference between commonly measured cations. So, commonly measured cations, ano yung commonly measured cations natin? We have your sodium and your potassium. And also your commonly measured anions, we have your chloride and your bicarbonate. So, there are only two commonly used methods for calculating your anion gap. So, this one or this one, depending kung anong given or makikita natin. If given ang potassium, so we use this formula. So, for your anion gap, it's either sodium plus potassium or without potassium minus your chloride plus your bicarbonate. So, your normal range for your anion gap is between 10 to 20 millimoles per liter. So ito, you can see this in your bishop. So this is just a demonstration sa ating formula of your anion gap from concentrations of anions and cations in normal state and in lactic acidosis. For example, pag normal nga, anion gap, diba, normal range ng ating anion gap is between 10 to 20. So this is normal. Paano ito na-compute? Remember your sodium. Sodium is 142. 142 plus 4. Ano yung 4? Potassium. So, sodium plus potassium. 142 plus 4. Isasubtract mo yan sa ating chloride plus your 28. Your 28 here is your bicarbonate. So, chloride plus bicarbonate, 103 plus 28. You add, and then you subtract, then you get the value of 15. How about if nagkakaroon tayo ng lactic acidosis? So, if ano nga nangyayari pag nagkakaroon ng lactic acidosis, nagkakaroon ng derangement ng ating environment sa ating cell. It's either tumataas ang sodium, tumataas ang calcium, mababa ang chloride, tumataas ang bicarbonate, etc. etc. So it depends. Kaya nga, nakita natin dito, yung sodium nagiging 141, your potassium nagiging 5. Then your chloride nagiging 103, and your bicarbonate nagiging 22. If you calculate this one, you get an ion gap of 21. So in short, this is high. In short, this is a high anion gap lactic acidosis. So basically, this is just a demonstration of how we compute your anion gap. So very simple. So of course, this will come out in your exam. So very simple lang man. Everything will be given. So there are a lot of reason why nagkakaroon tayo ng elevated anion gap. So ito yung mga different sources ng elevated anion gap. Dito acidosis kasi nga lactic acidosis. Nakita natin sa example, pag may lactic acidosis, nagkakaroon tayo ng mataas na anion gap. Actually guys, one essential gamit or tool ng ating anion gap is to differentiate what type of metabolic acidosis. Meron kasi kaming tinatawag na hagma and nagma. Ano yung nagma and hagma, Dok? Yung nagma, normal anion gap metabolic acidosis. Ang hagma, high anion gap metabolic acidosis. By the help of an ion gap, we will be able to narrow down our differential diagnosis. Kasi nga, nasa-separate yan. Meron kaming mnemonics na ginagamit for us to determine whether it is a normal anion gap or high anion gap na metabolic acidosis to differentiate what type of metabolic acidosis. So, actually, this will be discussed in medicine. So, I just want you to show this so that you will be able to familiarize with this. Isang useful tool ng anion gap is to differentiate your metabolic acidosis. Paano ma-differentiate, Doc? It's either high anion gap metabolic acidosis or normal anion gap metabolic acidosis. Yun tinatawag namin na hagma and ito yung tinatawag namin na nagma. Pag makompute namin normal anion gap, this is the possible diagnosis. Pero na-compute namin na merong metabolic acidosis ang pasyente tapos mataas pa ang kanyang anion gap, these are the possible diagnosis. So ito yung mnemonics namin sa hagma, high anion gap metabolic acidosis, MADPILE. So methanol, uremia, diabetic ketoacidosis, etc., etc., etc. So, MADPILE. So, tingnan nyo, elevated. So, high anion gap, these are all your MADPILEs nga mnemonics. So, di ba? It's easier for you to memorize. So, elevated anion gap, these are the possible causes. MADPILE. So, same lang yan, guys. Dito nakalagay, uremia, renal failure, ketoacidosis, methanol, ethanol. Same lang yan dito. Mnemonics natin, methanol, uremia, diabetic ketoacidosis, infection, iron. So you don't have to memorize this. I know it's gonna be a lot. So you don't have to memorize this. I just want to show na yung anion gap natin is essential for us to determine what type of metabolic acidosis. Is it a high anion or a normal anion gap? Kasi nga, with that alone, kung alam namin na may metabolic acidosis ang pasyente, kinukompute na lang namin yung anion gap para to determine or to narrow down our possible diagnosis. So you don't have to memorize this. I just want to show this one. At least you are familiar with this one. You will encounter this in your med school. Again, remember your mnemonics. Just remember the mnemonics. Mud piles and hard up. So, anion gap, meron tayong tinatawag na decreased level of your anion gap. However, it is rare, unlike to a normal and high. Di ba? Mas maraming mga differential diagnosis pag normal or high anion gap. Pero ang low anion gap, it's very rare. Hindi tayo masyadong nakakita niyan. May we only seen with hypoalbuminemia, decrease in unmeasured anions, or if there is your severe hypercalcemia or increase in unmeasured cations. So, guys, that ends our discussion. God bless you everyone and good luck.